So welcome everyone. This is the Critical Care Interest Group webinar series where we take the opportunity to promote members of SAM in the critical care world and be able to talk about what people are doing and what the cutting edge is. Today's theme is going to be resuscitation. 5 resuscitationists here. They've walked into a room and they're going to tell us why resuscitation is a thing and why this is the future for emergency medicine and critical care. I'm just going to introduce the panel real quick. I think that many of these people are already well known in their fields, but just for completion's sake, we have Dr. Scott Weingart. Dr. Weingart here received his medical degree and completed a residency in emergency medicine at Mount Sinai School of Medicine. He then went on to complete fellowships in trauma, surgical critical care, and ECMO at Shock Trauma in Baltimore. He is currently attending at NASA University Medical Center as professor of emergency medicine. Was an adjunct professor, or is an adjunct professor at the ICANN School of Medicine at Mount Sinai. Obviously, he is best known for his podcast on resuscitation and ED critical care called the MCRIT Podcast. It's currently downloaded more than 400,000 times per month. So let's I'll give a warm welcome to Dr. Scott Weingart.
Hey, folks.
Dr. Alex Bracey is a graduate of the Advanced Resuscitation Training Program at Stony Brook University Hospital and is now faculty at Albany Medical Center. He is the fellowship director of the inaugural class of the Resuscitation Emergency Emergency Critical Care Fellowship beginning in August 2022, where they're welcoming their first 2 critical care fellows, or 2 resuscitation fellows. Let's all say hi to Alex Bracey.
Woo.
Woo. Alrighty. Dr. Christina Lu completed a fellowship in advanced resuscitation from Stony Brook University Hospital as well. She's the associate director of the Emergency Critical Care and Resuscitation Fellowship, the associate director of the Emergency Critical Care Division at Hartford Hospital. Welcome, Dr. Lu.
Hey, guys.
Dr. Brian Wright is our dual boarded in emergency medicine and neurocritical care and completed his fellowship at North Shore University Hospital. He is faculty at Stony Brook University Hospital, where he serves as the fellowship director of the Advanced Resuscitation Training Program. Let's all say hi to Dr. Brian Wright. And Dr. Matthew Tichauer. Dr. Tichauer completed emergency medicine residency at Rutgers Robert Wood Johnson University Hospital, followed by a surgical critical care fellowship at Mass General. He is currently the director of emergency critical care and the emergency critical care unit at Hartford Hospital, and the fellowship director of the emergency critical care and resuscitation fellowship at UConn at Hartford Hospital, which is currently in its 5th year. Welcome, Dr. Tichauer.
Thanks for having me.
Excellent. And I'm Dr. Gregory Wu. I'm one of the emergency medicine critical care folks up at Albany Med. And I will be the moderator for today. I'm the Critical Care Interest Group chair for this year. So welcome everyone. It looks like we have an audience that is filtering in slowly, which is perfect. Welcome everyone. So I'm going to start off with a few questions, but certainly the audience is welcome to type questions in the chat, and we will address these questions as we go along. This is meant to be a really interactive session. So the first thing I want to ask to the group is, what is resuscitation? What is that to you? I think this is a question that for some of us who have been in the resuscitation world, this has been a obvious answer, but I think not necessarily for everyone in emergency medicine and critical care.
Well, this is a term I stole from the cardiac arrest people because we needed a description of aggressive critical care, specifically in the emergency department. But the term ED critical care really had connotations of people who had completed a critical care fellowship. So I wanted to just denote anyone in our specialty who's actually taking care of really sick patients in the way they're supposed to be taken care of, whether they be nurses, doctors, or even gastroenterologists, if they're willing to come in when a patient's exsanguinating from a GI bleed rather than saying, you stabilize them first. So pretty much anyone doing proper critical care outside of the ICU, in my mind, is a resuscitationist.
Excellent. I think that's a beautiful definition. So I'm going to ask Dr. Lu next. Why do it? Like you've gone through this. You've decided that this is something that you want to do for a career. Can you tell us a little bit why you picked this?
So So I decided to go into Resuscitation Fellowship because I really wanted to be able to take care of the critically ill patient beyond your standard time that we are used to for standard emergency medicine. So beyond the first 30 minutes to 1 hour, we know that people are boarding in the emergency department for longer. Critical care patients are staying for 6, 12, 24 hours. And I wanted to go into resuscitation to be prepared for that, to be able to comfortably take care of these sick patients for long periods of time, for 24 hours, for example, if need be. I'm not going to be working for that first 24 hours rather. And so I think this is where it's going. And I wanted to be able to really pay attention to these sick patients, to really take care of them well in the emergency department. And I chose to go into resuscitation to get that extra training and really to promote this field.
Great. Can I'll piggyback off that. I see two real advantages to doing a resuscitation fellowship, and I'm certain there are more, but the two that I can usually break this down into is, emergency medicine certainly gives you the tools to take care of critically ill patients, and a lot of the times it's the tools to get them to the next step. And I tend to think about it in terms of step one. Emergency medicine we are trained about step one, and occasionally step two, and then we're ready for someone else to kind of jump in. The way that I see the resuscitation fellowship and discipline as augmenting that training is a focus on the critically ill patients presenting, particularly the undifferentiated critically ill patient, that focus on mastery over that step one, mastery over that resuscitation component of that critically ill patient, and then being able to see the steps 2, 3, and maybe even 4 up to 24 hours, being able to care for them and not having to hand off, not saying what's the next step. The next step is dispo. I think that the next step we're always thinking about is what's the next step in care, rather than what's the next step in where is this person going. And that's something that I think is unique to this mindset that comes from this discipline and this training, is that sort of focus on what else can I do next? Why is this happening, and what else can I do next? And that's so the mastery over step one, and then the focus and the foresight into what must be done for the patient in subsequent steps is what I see about this fellowship is unique.
Yeah, and if I can also add on to that as well, I think that, I remember, I think Scott would say bringing upstairs care downstairs. And I think because patients aren't going upstairs, providing that care downstairs is extremely important. One of the issues facing emergency medicine in general is the onslaught of just volume itself. So today in emergency residencies across the country, they're doing really well at the kind of quick bread and butter type things, really good at phone calls and calling consults, but completely, and I don't think that they're not getting enough training in it, but I think that they could definitely use more training and advanced training in the critically ill. An aging population with more chronic comorbidities and diseases, living longer. The numbers are exponentially going up. And so in order to manage that, residents today are being asked to move the meat and do things quickly without kind of taking the time to learn what we did emergency medicine in the beginning. General surgeons used to do vascular surgery, and they used to do, every single operation that you could think of. And now we have general surgeons, we have vascular surgeons, we have thoracic surgeons. Even though the older guys now can do an aorta, they're not doing an aorta, right? So not only does this benefit the emergency department as a whole, I think it makes people better physicians, and it allows us to prepare for what is already here and what is to come in the very near and distant future.
Great. So I'm going to play devil's advocate and ask why you had mentioned that this is something that is not part of routine emergency medicine training. Could this be part of routine emergency medicine training? Our graduates are being asked to learn more and more. Is this something that is just part of routine in emergency medicine, or is this something beyond?
I mean, if you want to make EM 6 years, yeah, sure, go for it. But that's not practical and feasible in in a 3 or even a 4-year program sometimes, given that everything that an emergency medicine provider needs to know, and frankly, not everyone's interested in probably critical care, and probably not served with everyone sort of having to go through this this training.
But I guess having a resuscitation fellowship or having resuscitationists on your staff, though, it's unique because you can put a certain emphasis, just like we have ultrasound fellowship trained attendings who are promoting the ultrasound for all of the residents. I think resuscitations can bring up the level of critical care training in any residency, and amongst their colleagues.
Yeah, Gregory, your question could really be split into two halves, and Christina answered one of them, and it's the less politically contentious way of thinking about it, which is bring on one resuscitation doctor or ED intensive care doctor, and they'll be the person who's reviewing the protocols and figuring out how new things could be done, and they'll just be a force of good for critical care, much like a toxicologist or an ultrasound person. But the issue we don't want to deal with is that we, as emergency medicine, have one of the most wide spreads of skill set for the care of patients in any field I know of. You could have EDs like Hennepin, where they're doing insane level resuscitation. And then you could have places where they don't even know how to use ultrasound. And this still exists. They don't think video laryngoscopy is important. And so we could pretend that all of emergency medicine could do resuscitation, and that's the party line. And I really feel that 99% of doctors, if they were given adequate training and a real job to do it, probably could. But that's not the case. And so what it really comes down to is, I think our specialty will have a split, and emergency medicine, for the most part, will become 24-hour primary care and stabilization, which is what Bracey alluded to. Dr. Bracey alluded to, that first half hour, every emergency physician is going to be the master of that. And then there should be a second specialty at the referral centers that takes care of these patients after that first hour.
I like the expression 24-hour primary care. Having worked overnight urgent care pretty recently, I'll tell you that it definitely feels like 24-hour urgent care, 24-hour primary care.
I don't think that's a bad thing.
Yeah. No, it's I get to review the hypertension guidelines for 2021. It's great.
But I think it also goes both ways. I think, there are those who do the 24-hour primary care. I really actually like that a lot. But those who do the critical care who don't want to necessarily do the 24-hour primary care, right? The vascular surgeon doesn't want to take out the appendix, and they don't want to do cholecystectomies. They don't want to do that. And there are those who do want to do that. And so I think there is a niche and there is a place for all of this. I think one of the issues is going to be, we found this with starting the program. There are those who are in it, and they're the majority who went into emergency medicine to have, a certain number of shifts with this many people doing this and organized, and they did it for lifestyle, and trying to put this in as a supportive, I'll call it a supportive role for now, a supportive role. The idea behind it is not, or the benefits behind it are not clear right off the bat until they have 15 people that they're seeing. There's 60 in the waiting room, and now 3 critically ill patients just came in, and now they can't go and offer a sandwich to their guy who came in with toe pain or whatever, right? And now with the government asking for more demands on length of stay, and departments asking for, paying people based on press gainies and things like that, the advantages start to become clear as to why we are beneficial to have in the department. But, I think it's been a long, not a long road, but it's been a tough, arduous task in trying to prove to the rest, because it's been a 40-year period of doing the same thing over and over. So.
When I was looking for a job initially, one of the things that was asked a lot was, like, well, what is the benefit, just like you're describing, surely, anybody from an accredited program can do what you're describing. And, and as already been mentioned, if with the interest and focus, and, certainly people could do this job. But I think the best or one example that I typically would give would be, do you think that a PEM doctor or PEM trained person is more facile at taking care of the pediatric critically ill population? And I personally would, if my kid came in critically unwell, I would want a PEM doctor probably there taking care of them, even not critically unwell, versus somebody who's uninterested or technically has the credentials to do it. And I feel that there's a reasonable comparator there for resuscitation. Our focus and reason for coming to work being to care for this patient population. It seems reasonable to have that as another subdiscipline out of emergency medicine, because it is our focus and our passion.
No, so certainly I think that there's a strong argument to say that emergency medicine is complemented by this. Let's take the opposite side of detractors, because I think there are some folks who continue to ask why resuscitation is a thing. And I think the other major source of questions come from folks who are dual boarded and cross-trained. And a lot of folks in this group right now are dual boarded, cross-trained in critical care specialties, and they ask, why does there exist another critical care discipline? Who does this exist for? Why does this specialty come into existence in the last couple of years when there have been other existing critical care specialties?
Yeah. So there's Crippenslaw, coined by Dave Crippen at UPitt. And he said every single ED critical care doctor will start off saying, I want a 50-50 split. And every single one of them by the 5-year mark will be split to 100% one or the other specialty. And in almost every case, they want to be in the ICU. Very, very few of them want to be in the ED full time. And that's probably just due to the fact that there's very few niche jobs where you're actually doing critical care in the ED. And that might change. But my feeling is that resuscitation eventually will not be solely the province of emergency medicine, that some other specialties may choose to fill a unique role, which will be the management of a patient outside an ICU that is critically ill, with the goal in many cases of getting them downgraded to avoid that ICU. And what should be rolled into that specialty as well is rapid response. There is no one better suited to this role than the resuscitation trained doctors. And that might be one of the years of a anesthesia critical care fellowship, if we have our way, because it fits in perfectly. It's a completely wasted second year. They only did it as a sop to the surgeons to even make that a 2-year fellowship. Well, having someone trained in critical care and resuscitation could be incredibly potent. It's a different specialty, though. It's not critical care.
Great. No, perfect. All right. We got a couple questions coming in from the audience. We'll start with Natalie. Natalie wanted to ask, how would graduates pick a job that targets only sick patients in the emergency department? Do you imagine that billing and payment would be different? So why don't we tackle the first question? How do graduates go on to pick from a resuscitation fellowship? How do they pick a job? What does the job scene look like for them?
I guess I'll dive on this one. I feel like, and maybe this is my own perception of myself, so it might be distorted. I thought that I was highly sought after, but it seems odd to say. I will say that everywhere I went, at least I had something very different to talk about than I imagined many of my peers did. And it was really easy to target my conversations about what I wanted to bring to a department and what my role might be, both in terms of clinically, research, from an educational standpoint. It was clear what my role would be. Hopefully, my chair, who's I think in the audience of this call, would agree that that's what I've done. I think it was a pretty easy sell. you only asked the first half of that question, right? So I'll save the second half for later.
Oh.
Do you want to tackle the second half?
Unless Christina wants to talk, I'll let Christina talk for. I'm talking to.
So, just kind of piggybacking on what Alex said is that what's really exciting about the resuscitation fellowships that this is a very new field. And so a lot of times you're getting in at the ground floor and creating in a program what you would like. So when I was looking for jobs, it was, I want to help create an ED critical care unit, ED ICU. I want to help create a fellowship. And so I think because it's so new that everyone's excited about getting on this and they want someone to help out creating these programs, creating these initiatives. So what Alex said is that, yeah, you're highly sought after, but as far as picking a job, you kind of create the job you want as well.
Though you will be absolutely aided if they have already made the decision, and many big EDs have to make this decision of having a dedicated resuscitation shift. In many big EDs, they already have at least 8 hours, 10 hours, 12 hours a day where that doc is only responsible for the sick patients. If you find that kind of job, you could slot in super easily, especially if they don't have a really good, rigorous didactic and guideline protocol program to go along with that shift. And you could find many EDs like that. Now, if there's a place you want to go to that doesn't have that shift, it's a little bit tougher. Then you have to start talking about the idea of, well, what do you think about 8 hours a day where there's a consultant position where, I'll be seeing the patients after the regular team sees them and actually will take care of them until they go upstairs. So it is possible. But if you could find a place where they already have dedicated FTEs for resus that was just being manned or womaned by the regular emergency physicians, then that's an easy job to get.
But also,
I think the system is sort of critical in finding a place that, one, has a lot of critically ill patients, and two, has maybe a lack of ICU of bed availability, which leads to boarding in the ED unit will sort of be easier to sort of justify, that existence where you're there to see the critically ill patients.
But I think every resuscitation fellow graduating now is going to be a trailblazer, pretty much where they're going to have the tools necessary to, sell the program and the importance. It's not hard to sell it. It's hard to accept it when people have been doing the same thing the same way for so many years. So it's not just the tools that you have from a medical management perspective. I think it's also the political aspects of it, and political, I mean, speaking to your colleagues and administration and going that route. So it can be done, obviously, as it was alluded to. It's easier to go to a place that's already made the decision to do so. But once you get in, making the sale should be pretty easy, particularly with the specialized skill set that you have.
What Matt just said is the reason, or one of the main reasons, to do a resuscitation fellowship, because not only do you get the clinical skills, and you could argue, well, every ED doc at a good program would have those, maybe not, but what they clearly don't have is the logistical knowledge to start a resuscitation program. And that's what a good resuscitation fellowship will give you, is the capability of actually building that from scratch. And, hopefully we've given, under the leadership of Brian, our graduates adequate knowledge that they can trailblaze. And, that's what Brian really specialized in, is hopefully getting these people after graduation to be able to duplicate what we had. That's
You did a great job, Brian.
Yeah, I know. I had a lot of help, and I was lucky to have great people. It's really good to be. It's really easy to be a manager when you got great players playing for you.
Actually, I think it's an awesome segue into the next question that we have. Obviously, it's really hard to it'd be really hard to talk about how do you start a fellowship in just 1 hour. That's probably multiple discussions, and that's unique to every program. But I want to ask the group, how do you go about starting a fellowship? What are some challenges that you came across when starting one, and how'd you overcome it? Why don't we start with Brian and Scott, because I think you guys were really the trailblazers in all of this.
You hit it first, Brian, then I'll go on top of you.
Yeah. So we had the need. So, I mean, the first thing is you actually have to have, a need for this. So, but we had that before, we got there. We had, we were a big center, a lot of sick patients, ICU's full majority of the time. So a lot of boarding. Second, we had the physical space to provide, ED critical care. We had people with experience in ED critical care. I think we had buy-in from, our directors and fellow faculty members. By and large, the hardest thing was getting, the funding, getting, those lines sort of paid for, because, they're perhaps not, like other physicians that are going to be moving the meat and, seeing 5 patients an hour, and, and our fellows played a critical role in keeping patients safe and providing, critical care and teaching residents. But perhaps that didn't translate as, directly as, another attending who was, generating a lot of our views. So, that's what sort of, need, faculty ability, space, and funding were things that sort of we had to, address before we could open our doors.
But there's a lot of unique advantages to this fellowship. When Brian and I were conspiring, he said, I asked him, what he wants out of his academic career. And he said he wants to be a fellowship director, and he was built for this. He's ideal. And he was originally thinking a critical care fellowship, which has a huge number of logistical hurdles. The beauty of a resuscitation fellowship and what we came up with is that, first of all, there is no guidelines. So you're not constrained by the work hours and the standard fellowship stuff that you're going to get from a truly certified fellowship. It's where ultrasound was when it first started. It's kind of the Wild West. And as a result, these fellows can be working regular ED shifts to actually pay for their time. And that's what our fellows did. I think that's probably what they'll continue doing until we can't do it anymore, because it's a lot easier sell to give them, we paid them probably more than we needed to. I'm sure Bracey and Christina would disagree, but, we were basically giving them a half FTE salary, and they were working pretty close to that half FTE of non-critical care time. And therefore, it was kind of cost negative. You needed the lines, but you weren't asking for, could you give me these lines for getting nothing back to the department? And if you could, actually, if you paid them fellowship scale, because you just couldn't get the money, you could really actually go to a chair and argue that this is a huge money saver for the department, that all of a sudden you're getting what is in essence one full FTE of service between the two fellows, while the salary is markedly less than an FTE of an attending. So the money is the hardest thing, and that is much more doable than a formalized fellowship that has to, actually fit all the regulations.
I had a lot of trouble going to like surgery and medicine, and like, oh, this sounds like a really fabulous idea. But then, my ACGME is sort of filled, all the spots are filled, and they're, you're fighting for spots. Whereas, I was able to go to my chair and was like, yeah, we need this, and this will work a lot easier than having to go through someone who's a lot farther away, who doesn't have their toe in the ED and just didn't understand what we needed.
And then the fellows are an easier sell than actual resuscitation doctors, because, every time you put one of us in, it's actually stealing shifts from the regular ED attendings if they are filling a designated spot of resuscitation during the course of the day. That's hard. It's hard to hire an additional resuscitation or ED critical care doctor. A fellow's easy because they're not taking spots. They're working with attendings, and actually, not taking any of the sick patients from them. And the co-attendings, for the most part, love it, because all of a sudden they have someone else there when it gets super busy. There's someone who could actually, carry some of the load. And, that's how we sold it to them. But the real answer is that what the fellows did is actually brought the kind of care that Brian and I wanted to some of the attendings that might not normally do that kind of care. So even though you sell it as you'll be teaching the fellows, what really happens is the fellows carry on a consistency of quality of care when the ED critical care docs and resuscitation doctors are not there.
No, perfect. So I'm gonna play the devil advocate from the resident standpoint, then ask. So if residents ask you, hey, that's my patient, that's my critically ill person. And if you're lucky to have a dedicated ED-ICU where you can move the patient to a different location, great. But at the same time, if you're treating in place, how do you reconcile that resident who has been taking care of that patient, or that thing's been taking care of that patient? How do you reconcile that? Is that a loss of learning opportunity for that resident who's been taking care of that critically ill person?
So,
There's actually an ACGME right now is coming out to try to for non-ACGME programs in order to ensure that education is not taken away from residents. There's going to be some changes. Actually, I think they're coming in this year to ensure that. But we have a rule where if the resident's caring for the patient and they are either transferred to the ECCU service and they're cared for in place, or they bring them over to our ECCU Red Pod, the resident continues continuity of care. The fellow will jump on with them and the ECCU attending. I think a lot of this is self-selection, right? I mean, as Brian and Scott were alluding to, there are attendings who otherwise are not providing the not adequate but proper care after what they're supposed to be, in putting words in your mouths. But there are people who just don't want to do beyond that first 10 minutes, let alone 30 minutes. And so I think there's a self-selection, and having a program like this allows those residents not only to remain with their critically ill patient, but actually get a better understanding of the patient care and education, because you have somebody who's dedicated to that and a program and team that's dedicated to that. So I think it's actually enhances it. I do not think it takes away from it, and everything that goes along with it, obviously didactics and in real-time learning. And so I think that's a tough argument to make, that there would be any loss of education from a resident's perspective.
So like Matt said, I think there's a lot more bedside teaching when you have a fellow. The fellow, it's dedicated to just taking care of the sick patients. They don't have the kind of constraints the attending does, where they have to move to meet and see these new patients. You have a fellow who is not responsible for running the board. They can concentrate just on the sick patients. And so what you get really is you get so much more one-to-one bedside teaching.
Yeah, our fellows weren't stealing procedures from the residents. They were there teaching them. And it's like having a great EM attending who's interested in critical care, who is an emergency medicine physician teaching you, as opposed to having someone from a different service sort of teaching you about the same patient. So I only saw it as a positive experience, and they all do a great job teaching the residents, and our residents are grateful to have them, I'm sure.
Yeah, I mean, and in the situation at Stony Brook, it was a separate unit. And so there was multiple residents a day rotating through that. Having seen it in both ways, the residents who graduate from a program like that are just 10x better at critical care. There's no way you could pretend, and I don't know what the ACGME is going to write, Matt. I'm dreading seeing it, but you could pretend that you could have your continuity of care with your critically ill patients and continue to take care of the other 7 patients, but one of those 2 is going to fail. And just the way Press Ganey and the people that don't have endotracheal tubes in their mouth having the more ability to complain, it's generally the critically ill patients that fail. So a good resuscitation program, in addition to having a fellowship, would separate them out somehow. It doesn't mean there necessarily needs to be a separate ED critical care unit, but there needs to be some segregation from the residents who are taking care of the entire waiting room and the residents taking care of sick patients.
Excellent. Perfect. Tell you what, I see Paul, Dr. Paul Pepe has raised his hand. I'm going to unmute him just for a sec. For those who don't know, Dr. Pepe is a cardiac arrest extraordinaire. Conducted our last webinar. Paul, you're unmuted. I think you had something you wanted to ask. Paul, you there?
Yeah, I'm there. Let me get rid of this reaction, lower my hand. There you go. So I'm a cardiac arrest. Last I knew, I was still pulsing and breathing. So
the cardiac researcher extraordinaire. I'm sorry. But I'm glad you're still with us. We haven't had the zombie Dr. Pablo.
Yeah, it's great. Hey, listen, and Greg's run a great meeting here, so I really wanted to thank him again for having me here. So I'm going to give you 2. Mine's just philosophical perspectives to some extent, but there will be some practical aspects of it. One is why I'm here on with you today in a sense of my background, but two is my perspective as a chairman as well. So first of all, I got into this because I was a critical care person, and I began to understand that the earlier the intervention, the better the results. It became my mantra. And I remember at the Society for Critical Care Medicine in '83, I did my first plenary, and before most of you were born, by the way, and was able to, and that's exactly what I said. And I have several great examples of this. AEDs at the airport was one of the offspring of all that when we brought it to the streets. I was in Seattle at the time, and I began to understand is that the earlier the intervention, the better results. So it was kind of cool. But then here's what I developed then was this concept that I was now responsible for doing what? For stewarding care all the way from the time, actually now someone calls a dispatcher at 911, right out into the ICU. And that often involved me actually going through in a lot of my research I was doing, going even into the operating rooms and making sure that people weren't screwing up on things. I was stewarding care all the way around and transmitting communications and said, we are considering that there may be a pneumo here, anesthesiologist, you should know about it. So maybe mine was to an extreme, but that's what brought me here and why I wrote The Chain of Survival, which, by the way, I actually stole that from Fritz Anung back in 1968, who had the Residency. It was fantastic. But the concept is that we had a steward care. That brings me now to the chair thing. So as a chair, I had a whole different perspective as I saw people were very ED focused, emergency center focused, okay? And as opposed to the fact that emergency medicine, as Scott was alluding, is broad. It could be toxicology, it could be sports medicine, it could be pediatrics, it could be observation medicine. Our domains are out there. Taking a European perspective, where they actually have critical care units in the emergency departments, in their A&E departments, and they actually have people specializing there. So that's going to, if you can, bear with me just a little bit, indulge me a bit. I was going to give you a perspective from a chair's point of view. So first of all, I was fortunate to have that broader perspective that we basically had that entire domain, and it gave us a lot of help. But what I found was when I started coming into the emergency department, or more importantly, into the streets, I was bringing physiology that I'd learned as a critical care specialist that they were clueless about, quite frankly, in the emergency department, and they appreciate it. And I was considered, even to this date, considered they like having me there where they have a critical care person because I can give them better direction about how to handle this auto-PEEP patient or whatever it might be. So those are the things. And if you're going to develop a fellowship, it has to involve research, education, because this is what the dean's going to want to know. If I create a department or a division here, I got to have research, education, and training programs within that. And so those are part of the things that you do bring value added. And all the things we've heard today about being there and wanting to take on people. But even as a chair, you could have assigned people to take care of the critical care areas, but as long as you're having the residents rotate through there, and all the things we heard were just fantastic comments today. I just want to say that. But let me just point out three things. So first of all, if you come to me and you've been trained in critical care, or let's call it resuscitation medicine, I don't care, you bring value added to me as a chair when I'm hiring someone. I have to make a decision between this person or that person. There is clear value added. And I have a bias because I said, I know that they know more about physiology than most of the other folks that we have, that are out there right now. So that's number one. Number two is that we are actually bringing critical care in resuscitation efforts, such as Scott was again alluding to, like what we do up in Minneapolis, that we're, or in New Mexico, or other places in Milan, where we're bringing ECMO to the streets, or we're bringing other, critical care things that we really need to know about in those things. So I kind of like what Scott and some of the others were saying, is that we are kind of more resuscitation persons that were there. And I think I also understand finally, understand why people end up being in the ICU eventually going that way, because I think we spend so much time in the emergency department on computers instead of seeing patients. And I could see 5 times as many patients if I didn't have to do all the paperwork that I have to do, quite frankly. Yeah. And
I think most of us could see a lot more patients. We didn't have to do the paperwork.
yeah. I mean, that's what it's about. And
Yeah,
I
yeah.
mean, sincerely, I really said, I'm not working in the emergency department anymore. I'm just going to either be in the streets or going to be up in the ICU, because I want to really focus and think more through this critical person that could be a lot of different things that cause this situation that I'm dealing with right now. So when I go see an 84 hypotensive woman who's got melena, but she's got, pink, mucous membranes, and she's got a tachycardia with dope P waves at 150 a minute, and she just had pericarditis from COVID a few days ago.
Yeah.
It's going to take some time to sort through this. It could be hyperkalemia. It could be the pericarditis. It could be a GI bleed. Who knows?
Yeah,
But,
I think that's definitely definitely a great role for resuscitations. I actually, just before we move on too far, I just want to bring back one thing I think really interesting that you brought up. That is interesting. I want to bring this to the rest of the group, is actually the role of academics. I mean, I think that's one of the things that defines a new subspecialty, right?
Absolutely.
Is its own body of literature and its own specialty. I'm gonna toss this one to Dr. Bracey. How do you generate a body of literature for a new subspecialty? Because I think this has been one of your big focuses for your fellows and your group, is how do you make an academic output from a group? Or for a new specialty?
I don't know. I'm trying to figure this out in general. I think that critical care research is super hard in general. And so I'm sort of navigating these waters right now. But I think when you have a discipline whose focus really is just, again, mastery over step one, and then, the outlook on the steps through hour 24, I think you can develop some new questions that are specific to outcomes that matter to us. So I don't know is a really short answer to what you're saying, but I think that we'll have a new way to focus on it with and a new workforce in fellows to be able to focus on questions that frankly matter to the patients hanging out in the in the emergency department, like when to come off BiPAP or something like that. But it certainly, I think, is a truly important part of any fellowship program, and I think that there's just so much out there that's unexplored, partially because of the difficulty, but also I think partially because it's there hasn't been the opportunity to really be able to focus on it, maybe, or maybe I'm making that up. But it will be something we'll definitely keep a focus on, and is certainly in our program.
I think the Resuscitation Fellowship and those who graduate from Resuscitation Fellowships, if you look at generally how subspecialties throughout the hospital view the emergency department in general, oftentimes from a general perspective, it's called the pit, right? I mean, no one wants to go down to the pit. Speaking to people downstairs about research and coordinating research between multiple subspecialties, I think this fellowship allows for, I don't know, I think emergency physicians are not given the respect that they're due, but I think this allows us to kind of explore different areas that we otherwise may have not been included in, because we're starting to go beyond just the emergency medicine basic research that's being done. I mean, ED-ECMO, the Minnesota consortiums, things pre-hospital care and critical care, showing benefit for TEE in the emergency department. Who's going to do that? The one who's been doing emergency medicine for 40 years and is really good at making a quick diagnosis and getting the patient admitted? No, it's going to be the resuscitation fellow who just graduated, who's really excited and got, a fire under them, like Alex and Christina, who just finished, and who's just has this excitement for what's new and what can be explored. So not only, again, are they going to be trailblazers from a initiation of new program perspective, but also advancing medical care in general. We see everything downstairs, right? So the critically ill are the ones that matter the most, and early intervention. And so those procedures and that research, I think, those are the people that would be best suited to lead that research, or at least be the center point for ultimately other subspecialties.
Awesome. I love it. Looking at our audience, I know that we have a few folks who are in various stages of training, some medical students, some residents. Rick Tuminello asked the panel, as a future applicant, could you highlight some of the differences in the current fellowship programs and what makes for a competitive applicant to a resuscitation fellowship? And I think as a panel, basically of program directors and associate program directors, this is a great question to ask. So I'm gonna ask Christina. You want to start the discussion on this one?
I guess I'm going to answer. I guess as far as what makes for a competitive applicant, I think that we're looking for someone who's highly motivated, who's very interested, who has, when we talk to them, a good personality, who has a really defined. They know what they want. Like we like applicants who are dedicated to resuscitation, who really want to, when they're here, do the research, see the patients, be active in their learning. We're trying to look for that motivation in candidates. A lot of people like to ask, do we need a lot of ICU experience? I think it's not so much experience, it's more the desire to learn. I think that's what we're really looking for. Someone who's motivated to advancing advancing the fellowship, to bringing something to the fellow. I don't know if that makes sense, but and going back as far as what are the differences in the current fellowship programs, I think a lot of us are kind of, we started off with Stony Brook, and from Stony Brook we modeled our Hartford one somewhat off of my experiences, and I think perhaps that Albany has something, Bracey probably took some of his experiences to Albany. And so I'm not sure they're all, as far as just, there is some difference as far as like the ICUs that people are training at. And I don't think there's a huge difference. I think all of our programs are good, and they all are sort of off the same foundation, so to speak.
Yeah, there's definitely going to be some. Oh, sorry, Brian. You want to talk?
No, you go.
I think there's some differences as far as like how much time in each of the ICUs and which ICUs, and some of the electives are different. But I think fundamentally,
and I think we're all three clinically based resuscitation programs, as opposed to like a basic science or research program. So I think that's important. Whereas we're perhaps training you more to be someone who's very clinically adept and working, as opposed to someone who's more interested in basic science research or epidemiology or those sort of things. So I know Stony Brook's focus has always been on sort of the bedside application of ED critical care and resuscitation.
Yeah, and can we work next to you for 12 hours a day or 9 hours a day, 15 days, whatever, however many shifts you're going to do? Are you somebody who, to be honest with you, that's a large part of it. Are you somebody who is enjoyable to work alongside? And I think that comes from your experience during residency, and will come from your letters of recommendation, and we'll be able to see that. So.
I think we used to call it the 2 a.m. test. Can I stand being next to this person at 2 in the morning when the ED is burning down?
That's right.
It's more motivation to learn and a good attitude than perhaps getting all the ICU experiences out there, so to speak.
Yeah, and I think at the beginning you'll find that you really have a strong desire to take internal applicants, because you know exactly what you're getting. And as to Matt's point, that more than anything else, you're going to be spending, as the program director, a ton of time with these people. And if it's already a known quantity, it's really hard to push aside someone who's just the strongest person in the program, which is generally what these fellowships get, to take an outside applicant who, in these current COVID times, you might only have met on Zoom for a half hour and then spend a year with that person. We've been burned once or twice.
As far as and I think just the difference between programs things, I think that like Christina said, we're really all, I think, have the same mindset. You're going to get good resuscitation training, and I think it really just boils down to which rotations are different, and then what's your curriculum structure that's slightly different. I know Greg is being modest. He's the assistant program director up here, associate program director up here, in fact. And so we're helping to write a curriculum and find the articles and such that we're looking to make sure that everyone has. So it's minor differences like that, but all same clinically focused, relevant training.
And I think something that's really important is survival of this field is anchored on everyone being successful. And I think that, all the programs, obviously right now, 3, but everyone's interests are intertwined. So obviously we'd love to see this become something nationally and more recognized as a fellowship program across the country, more so. But there has been discussions between the programs, and so everyone kind of has idea of what everyone else is doing, and trying to make it a standardized approach, right? If you're a discipline and you're a field and you want to become that and become something that's standardized for the future, you have to teach the similar things the same way. So I think that's something important. And again, that's the ACGME. Again, we don't know what's going to happen with that, but I have a feeling that we're going to have to adhere to a certain protocol and standardization across the board.
Actually, I think that brings us to perhaps maybe the one last guiding question, and this is a little bit of a tee up. Right now, there is no, other than the EM board certification, there's not really an accreditation pathway. These are non-ACGME accredited fellowships. Is there a role for accreditation? Should this be something that, as a growing specialty, should be pushing for accreditation? Is that beneficial? Is that going to be harmful? I'm kind of curious to see the audience. I'm curious to see what this panel thinks.
I think that there is a path to legitimacy, and you don't want it too quickly. You really want an established entrenchment of this as a subspecialty when it's still easy before the accreditation occurs. So yes, definitely in the future. And then, everyone retroactively gets their, imprimatur, because they once the credentialing and certification comes through, then everyone just, gets it eventually. But getting it now would be the worst thing in the world, I think. I think it would lose a lot of mobility and agility to actually start these programs. So I'd love a decade from now for the accreditation to come.
I guess the opposite driving force for that is the or I guess a counter force is what that's called, is the people having to deal with the questions of like, what the heck is this kind of thing. And I think as Dr. Weingart pointed out, in 10 years from now, ideally the momentum continues. There's multiple more programs. They're not primarily located in the Northeast or entirely located in the Northeast. Then I think it's very easy to make the case for it, or the legitimacy is like implicit. But the accreditation in whatever form it comes in, and I know there's ACGME and there are many other like recognition bodies that will just help with the concept of existing and what that means in terms of the the House of Medicine in general. And so that's I think ultimately the benefit is of recognition is legitimacy. So.
And we're in the nascent phases of forming an organization specifically for ED intensivists and resuscitation doctors. And that organization, if it does get off the ground, could absolutely give legitimacy to these programs without the burden of true ACGME regulations. Now, there's a double-edged sword there, but that's the way neurocritical care started, and I think that's a very good pathway to progress.
If I can ask, is there a name for this organization, or is this still top secret, not quite ready for prime time just yet?
Society of Emergency Physician Intensivists and Resuscitationists, SEPR.
I love it. You already have an acronym. That's how you know it's legit.
That's all that matters. It's something to spell.
All righty.
Hey, Greg?
Yes.
I don't know if you can hear me or not. I'm trying to figure out which one I'm on here. So here we go.
Tell you
Get
what,
rid of
I'm
it.
going to mute you on one of these because I think we're getting a little bit of feedback. And then we lost you.
Hey, I just wanted to point out when we were talking about the fellowship and accreditation, all that, the main thing that obstructed, for example, EMS is now a subspecialty in the House for Emergency Medicine. And the main thing that held it up was trying to define what the special competencies are that are there that cannot be obtained through a residency program. That's kind of one of the defining factors. And so when you are doing such a thing, if you're going to go and advance into this area, define why it cannot be obtained elsewhere. That's an important point. And getting back to what Matt said is that we've got to make sure it is sort of everybody's in agreement and it's going to fly up front if you really want to proceed in that manner. That's it. Sorry about the double thing. I'm trying to get out of here. I'm on the road here pretty soon. So
we understand. Actually, we got time for maybe one more question. I'm just going to ask the rest of the group. What are some experiences at the fellowship that you would want to see in your fellowship that's unique that would not come in emergency medicine? Is there something that you would want to be kind of standard for resuscitations to see or learn before they go out into the wild?
I don't think there's a standard thing that needs to be seen outside of, I think, what should be standard for all fellowships in all settings, because as was referred to earlier, it's not every place is going to have an EDICU, hybrid or otherwise. What should be standard is that I think the whatever setting it is, the fellow is expected to be at all resuscitations, irrespective of whether or not the fellowship director or an EM intensivist person is there. I think it would be ideal for them to just be at every single resuscitation, getting reps, again, not stealing procedures, but being involved in all of the undifferentiated acute presentations of patients. Because like everything else in, I think, medicine and life and whatever, it's in large part reps. And seeing something multiple times from multiple different angles really just is the best possible teacher, I think.
So same thing. So what I got out of my fellowship when I did it was that I thought the greatest benefit was the sheer amount of exposure you had to critical care and the, what's that term? Stress inoculation do you have? That, like, how can you handle multiple super critically ill patients all at once? And that's what the fellowship really does well. And I think all of these resuscitation fellowships is giving that exposure and that experience, and also teaching you the skills to manage multiple sick patients at once and doing it well.
Yeah, and the fellowship, if it's done well, should build a mindset that is unique, because there's the anal retentive obsessiveness of an intensivist, which is absolutely necessary and lacking in many emergency physicians by personality and by choice. But then there's also the need to deal with chaos, and then things are not going to be carefully structured and easy. And so that is a mindset of the ED intensivist, and it can absolutely built into a resuscitation doctor in 1 year.
Perfect. Well, I think
Great.
It definitely sounds like we need to continue to make sure that we push our trainees to see it all that they can and repeatedly. We're at the top of the hour, so in respect to everyone's time, I think we're going to close out the session. I think that if there are further questions, I'm going to, if our panel wants to put in contact information, otherwise you can certainly email me, and I'm happy to feed questions along to the rest of the group and put people in contact. I just want to see, does anyone have any closing thoughts before we're called tonight?
Thanks for having us. Thanks for doing this.
Thank you.
Yeah, this is great.
Thank you, guys.
Excellent. Perfect. Well, excellent. Well, I appreciate the panel's time. This has been an awesome discussion. Feel free again to reach out to anyone's email on the chat. Certainly, my email is always open, and I'm happy to feed questions to the experts on this panel. Thank you again, everyone, and thank you again to Doctors Weingart, Wright, Lu, Bracey, and Tichauer. Thank you so much.